He's 81 years old. He's here for a 1-year follow-up. He shared care with Dr. Cavallo. Records were requested. His BMI was 30.46. He was seen by nutrition in 2015. I was wondering if you want to make a follow-up appointment with them.
Yeah, you can try getting him in the same day as he sees me.
Okay.
So he doesn't have to make a separate trip.
He declined to move at his last visit, so I don't think he'd be willing to do that. He was seen by dermatology on June 30th for a superficial skin cancer, and it was treated with Efidex. He's 44 years old, here for a 6-month follow-up. He also had a high BMI of 36.99. So I was wondering if you wanted to refer him to nutrition or move.
Yes.
Which one would you rather?
Well, we can see
Okay.
about scheduling a nutrition appointment the same day, and then we can talk to him about doing a move when he comes in.
So he has back pain. So he was referred to the non-VA chiropractor, and he's using a TENS unit and gabapentin. You called him previously, and he felt this was working well. He's seeing allergy clinic for injections. He saw GI on June 17th for GERD and rectal bleeding. He had an EGD and colonoscopy on September 5th, and he had H. pylori and a tubular adenoma and polyps, and he was told to repeat in 5 years. I called him for his Hep C, and he declined, and he's seeing mental health for PTSD.
Okay, and his labs are all set.
And that's a word, yep. He's 86. His CAN score is 95. So he is shared care, so maybe when we see him we can educate him that he can come see us rather than go to urgent care. He's a 6-month follow-up. Shared care with Dr. Signorello, which his records were requested. His labs were ordered. He's being treated for bladder cancer on the outside. His last visit, his creatinine was elevated. You called him and he declined to see VA renal, so he went to see an outside specialist.
Mm-hmm.
I called him and he didn't pick up. I'm just awaiting to get the outside provider info so we can get the records for that.
Yeah, I definitely want to see the renal notes from him.
72. He's a 6-month follow-up. He again has a CAN score of 95, so if we can educate him on coming to see us instead of going to urgent care. He had a lung nodule, so in your last note you wrote that he's due for surveillance in March of 2018. Do you want to put in the lung cancer screening consult?
Yeah, let me put that in right now.
He's followed by optometry for ocular hypertension, and he came in August for a sick visit. He was seen for numbness and weakness in his right lower extremities, and he was referred to neuro, and they did an EMG and MRI.
And then it looks like they felt he had neuropathy as well. Okay, so let me just put this lung cancer screening consult in. This patient's also having a surveillance CT and urology follow-up in January for his renal cell.
He's 36. He was seen in September for lower back pain. He previously had lower back pain and was seen by pain clinic, and he received injections. So Eileen re-referred him to pain clinic and put in a pool consult. He had a BMI of 32.29. Our nutrition consult was placed by you at last visit, but he canceled. So I just wanted to make sure it's okay to put in a consult again when he comes in.
Yeah, see if he can get scheduled the same day.
He's 85. So he saw you in September. In your note, you recommended he have a 6-month follow-up, but this is only 3 months. So I left him a message to see if he needs to be seen, if he scheduled it for some reason, or if we can see him in March 2018 instead. So, to be determined. I did not order labs just because he doesn't need to be seen
you can
right
see,
now.
he can push out his appointment 3 months to make it the 6 months. I don't need to see him unless he scheduled it for another reason.
Okay. He's 62, 1-year follow-up. His CAN score was 95, so if we can educate him on coming to see us. At his last visit, his LFTs were elevated. You advised him to stop drinking alcohol, and then you ordered follow-up LFTs, but he never came for his blood work. He had an ORIF of his left foot, and then he's followed by neuro for a seizure disorder and brain tumor, which is currently in remission. And then there were no labs ordered, so see you for labs.
So, I would put him in for annual labs, since it's been a while for him. And let me just check and see if he wanted PSA screening.
Order the PSA?
Yeah, he did want screening, so, he's gonna need that. And I think he is in the confirmed study, so I think they're gonna take care of his fit test. And he also saw neuro. And he's supposed to be seeing the seizure clinic, so we need to make sure he has a follow-up. Well, they canceled his appointment November 15th, so he's gonna need a follow-up seizure clinic.
Okay.
And actually, his colorectal cancer screening is up, so he's gonna need a fit test.
I think the seizure appointment was canceled because he saw Dr. Domingo Horn on November 3rd.
Yes, but that was for his brain tumor, not his seizures. And they wanted, in that note, they said they wanted seizure clinic to take over. The other thing is we put him in for bone density and he didn't schedule it, so we need to see about getting that scheduled. All right?
And that's it for December 11th. While we were pre-planning, anything that Deborah was saying that needed to be added to the pre-planning sheet, I was documenting on my sheet, and then after I'll go and update it. Kim was marking off any patients where the labs were ordered, she was highlighting them, so then after she'll call all the patients and remind them to do their labs 7 to 10 days prior to the visit. And Yen was following and opening up all of the patients in the computer, and then if Deb asked for any additional labs or cancellations or to add any consults, she was putting them in during the pre-planning meeting.
We're trying to promote access for our patients. So a big part of that for us in our primary care team is to pre-plan. So part of pre-planning is reviewing the upcoming patients, making sure we have any documentation that the provider has requested. We also do discharge planning in that, 2-day post-discharge calls that Erica and I do together. And when we do that, we get all the documentation and bring patients in. So we're adding people into our pre-planning sooner than we are pre-planning for. We generally pre-plan 2 weeks out. We gather the information, we review anything we maybe can go over via a telephone call so that the visit runs smoother when the patients arrive. And we work on that together. Erica's new to our team, so she's now learning the process. We have a great tool, the Time Saver tool, which makes pre-planning much easier. But we have to make sure that we set aside time to do it so that we're adequately prepared for the patient so that we can give them the best appointment and face-to-face with the provider as possible.
And I'm new to primary care, but I feel like the pre-planning process is really important. We get, I order all the labs before, and, the doctors really know their patients, and at least they're a little bit more prepared for the half hour they have with the patient. So it's really helpful.
Well, part of pre-planning is reviewing past notes and any other notes from specialties that the patient has gone to since they've seen their primary provider. Primary providers generally will put a little note at the bottom of what labs they want for next time so we can enter them, any other tests they want, any outside documentation they may need. And our local hospital is really good since we're further away from the major hub of the VA in Boston. They send us documentation, so we're always reviewing that on a daily basis. So we can find out if a patient has been seen outside. We have a lot of shared care here at our clinic, so our provider requests a lot of outside documentation to review. So being well prepared in pre-planning and getting that documentation so the provider has time to review it makes a huge difference in how well that short visit goes, especially when they have a lot of outside care.
I feel like that is the biggest challenge too, is the shared care is important, but it's a challenge, and it's important that the provider tells us what they need for the visit so they can, talk about outside care that they have.
Right.
So it's a challenge, but it's important.
We're now not so new to the community, and the two-way communication we have with them is very important. I've had really great interactions and conversations with outside providers that are like, hey, you've done the lab work. I don't need to repeat it. Can you fax it over to us? And we have, the patient sign a release to make sure that the consent is in place to go back and forth. And I know we're working with a new program, the VLER program, to make sure that we will have like a two-way door with patients. So we're working on that, getting that here. Our biggest challenge is medication. So having patients understand the shared care policy, and that it is their responsibility to provide the documentation needed for medications they want to have filled at the VA. Our elderly patients, it's a challenge to get them to do that. So, our MSAs are wonderful here, and they really try to accommodate the patients that are understanding the policy and getting the outside documentation that we need so that we can provide them with the medication that they want to get through us.
Pre-planning, we are required to go to at least 2 a month, again, because of being in more than one place at one time, and if the desk if we're needed at the desk. But I go, and that's when they give me requests for outside medical records ahead of time. But now we have the green sheets that we use for outside shared care patients. So hopefully every time they come in, they get a green sheet, and they provide us their shared care information, which helps with the pre-planning because the information is in the system. We created a shared care form that every patient that checks in gets a green sheet, and they put if they have just VA care or if they have outside private physicians, and then we enter the system, enter their outside providers' information into CPRS. Yeah, I think it's better patient-centered care because we know what's going on with the patient before they show up, and you're not blind as to why they're coming in, whether it's an annual, a sick visit, or other.
I actually check in the veterans when they come in for our team and other clinics, and I do my pre-planning sheets. I enter all the labs, and then I also enter if they had opioids, if they're on opioid agreement and stuff, and then I actually take those Huddle sheets, make copies of them, and I hand them out to our team. So that way they can review them and see what else the veteran needs. The visits definitely go much smoother.
So the pre-planning actually revolutionized our efficiency and also getting all the information needed prior to me seeing the patient. So my PAC team RN will get the information from the chart, what are the pending issues in terms of immunization, in terms of his previous visits to urgent care, and also any phone calls and secure messages. And all that information is being pulled and given to me as a nutshell. What are the pending issues that I have to address? So it's improved the team's efficiency because time is very precious. Shared case, it looks as if most of the work is done outside. Actually, coordinating the work done outside, getting the information, because most of our patients, actually, some of the issues were being brought to their attention when they see me. So getting information from their provider outside in terms of getting the records and getting that information faxed to us, new prescriptions. So this is actually sometimes, shared care can take more time than the patient that we are managing completely with our own specialists and pharmacy. And also the monthly meetings are very helpful because we kind of look into the things that we learn, from our pre-planning, and then sharing and then getting the input from each member is very, very helpful. So that way, I will have less anxiety in terms of unanticipated problems, and also getting work done prior to me seeing the patient. It gives a lot more forecasting the problems, and also maybe delegating anything that could happen the next day. It actually, if it is done smoothly, efficiently, it reduces your time when you really having an encounter with the patient during the clinic time. It's very, very efficient. Anytime you introduce a new concept, people think it is time consumption, and then they don't incorporate. But this is one that really makes your clinic time more efficient, and also you are addressing all the problems. It's not a broken care. Once you prioritize issues prior to the clinic visit, there's always a room for incorporating whole health concepts. And I started actually adding those questions into the template so that I can narrow down that I fulfilled what the patient wants. And we actually learned from those questions, how the patients read the questions differently, answer the questions differently. But once you narrow down and focus on particular questions, it actually adds the quality to the whole patient visits.
So this is our morning huddle. We huddle every morning at 7:45. My name is Yen. I am the team RN. This is Deborah Rusinos, the nurse practitioner, and this is Allison, our LPN. Okay, today is Monday, February 12th. How is everyone doing today?
Great.
Good? Great. Okay, so this is your schedule today. You have a couple of openings at 8:30 and 10:30 and 11. I added a telephone call for you at 11:45, like you requested, and then you also have another telephone call at 4:30, and a couple of openings in the afternoon, 2:30 to 3:30. Check the spotlight data. We're still at 100% for everything, so we're doing good. Sarah's out today, so Allison will be covering. We're going to be doing whole health on your two new patients, your 10 o'clock and your 2 o'clock.
Can you put whole health for the 8 o'clock? It's a 1-year follow-up.
Sure. So Allison will do the whole health. And is there anything else? And anything else?
Can you make sure we have the discharge summary on my 1:30?
Yes, we already got that. So it
Okay.
was all set.
Good. And then,
Okay, in your communication folder, I'll give that to you. There's really not much in there, just a VNA that needs to be signed. And that's it.
okay, looks good. Thank
Okay.
you.
Great. Have a good day, everyone.
All right, you too. Bye.
Monday morning, we have 2 clinics today, almost full clinics actually. We have very few openings. We also have 2 new patients, 1 on each team, and a nurse clinic coming in at 9. Your 11:30 is here. I was gonna see if you could see him before your 9:30. He's here for. He's gonna come back at 11:30. It's up to you.
Yeah, no, that's fine. If he's here and we got spot time, fine.
Okay,
Might as
so
well
that's
move
gonna
the
be.
line along.
We're gonna move it to 11:30 to the morning. We also have 1 death, and Dr. De Bruyne is working on the certificate.
Yeah.
So that's my urgent issue for this clinic.
Okay, no, you gave me that. I'll sign it. We get it back to him.
Okay.
I've called the 2 o'clock patient multiple times to try to get any records, and I haven't heard anything back, so we have no records for that patient.
Okay. Thank you.
And then Mr. C, this telephone clinic, when did you want to book that? Any idea yet?
Any time
This week?
we have a spot. Yes, I sent him a letter about that. I don't know, he won't get it probably for another week, the letter.
Okay.
But I want to let him know what's going on.
Okay.
Because I couldn't reach him last week.
Anything, Nina?
I called all your patients except for Rivera Jose. The main labs is full, so I cannot leave any message, but everybody's and they are aware in there.
Okay.
We continue. We have a short week this week. I'm not here on Friday. Are you here?
I'm not here on Friday either.
So you don't
I'm
have
not here on Friday.
I'm here on Friday.
Right. So you might be supporting another team on
Can
Friday.
you just take care of everything, please?
Yes.
Yes.
So we're at 100% for both PAC teams on the reminders, and we are currently working on Time Saver 3, improving pre-visit labs with letters and phone calls, and increasing the compliance with the opioid policy.
Okay, and for highlights, we have our winning MSA. She got highlights during the last staff meeting, so congratulations.
Thank you, Mina.
I wouldn't be able to have that without the support of the team, so it's everyone.
Great morning, everyone.
Good morning, Katie. Good morning, Erica.
I have to leave for school at 2 o'clock, so I'll be leaving early today.
But I have Erica, is that correct?
Yes, Erica's
Okay.
here. We got Erica all day.
Okay.
Your schedule's really full today. You do have that hour PMT to address any issues that we have
stuff, yeah.
going on. I don't think we have as much today. We do have a opiate renewal today for one of our patients, and Erica's done everything for that.
Okay,
So we just
sounds
need to
good.
review it, we put the note in and everything for you. We have no open slots today. We don't have any open slots next week either. Your schedule's full for the rest of the month. Let's see. Our second patient has been in and out of the hospital and had VNA care. He's got a foot exam due today and he's got a ton of reminders, so we'll tag team on that one to get through everything because he's got a lot of
Time's up.
vaccinations,
8:30.
or 8:30 patient, yeah. The memo list came out, we only have 3 patients on it, and our 9 o'clock patient is one of them.
Okay.
That we need to address that with her.
Okay.
We didn't have any discharges, so we don't have to worry about that. I think we've already gone through the secure messages this morning and addressed everything, so we're good with that. I just have one more VNA for you to sign off on. And, let's see. Oh, your telephone clinic, today is to discuss the new blood pressure medication.
Yeah, that's enough for me to know if
Okay.
it's effective.
Yeah, he was concerned
So I say we
about that.
keep that on the books.
Okay.
And I will call him.
Yeah, he was
Yeah.
concerned about that, so.
Yeah.
I wanna do that. We're doing great on, all of our reminders. Your schedule is full in March as well for recall saturation. But I know that you have that, clinic change, so I
Yes.
think we'll be able to accommodate that. So we'll go back up to that. Let's see. Erica, do you have any concerns?
No, I'm gonna wait until we.
Okay, so why don't we,
meet.
so basically I'm gonna try to get through the morning by 1 o'clock,
Right.
including notes. So we'll plan on meeting at 1 o'clock
Yes.
to bang out Florentine's stuff. And then I had a couple of things, just 2 things. This guy, don't get the patients with the same last name mixed up. This is a different one.
Yeah, okay, so
Okay,
not the one
so
we're
not
just
the one
talking-
you're
okay.
thinking about,
Alright.
this is a different one. So can you just, his BPs are actually dipping a little bit on the high dose lisinopril. So I changed his order to cut it in half. Can you call him and tell him to start splitting that pill in half?
Sure.
And to take 20 instead of 40.
Sure.
So that's him.
Maybe come in to see me.
I think he's
Or
got,
no?
he has telehealth going.
Okay.
So he's gonna cut the dose and then we're gonna be continuing to follow
Okay.
him. And I don't know why it's going down, I don't know whether he's losing weight or something, which would be great. But he's like now over controlled, so
Okay.
backing down on the ACE will help. This lady, we saw her last week, I put her in for repeat TSH. So she just needs to come in and get the paperwork for the blood work
Okay.
to get that done. I e-consulted endocrine on her and they're not super excited. They think if we recheck it, it's gonna come back normal. So
Okay.
just let her know that I put in the order. She needs to come in and get the paperwork.
Okay.
That's all I got for now, and then we'll touch base at 1.
Yeah. There was that patient you wanted me to call.
Yes,
So
I wanted to
talk
hear
you.
about that.
Yeah.
And your first patient is ready. So every day, Erica or I will go into an email. We get an email, a spotlight report. The spotlight report is the major things that we're tracking. Right now, we're tracking tobacco, depression, colorectal cancer screening, diabetic, foot exams, and flu vaccines. So we look at that every day, and we try to find out, did we miss something? Are we waiting on outside documentation for a foot exam or colorectal cancer screen that was done outside, to make sure that, we don't miss, an important reminder for a patient to get health care so we can be proactive about their health care. We have all of our patient appointments up there, so we know how busy our day is. We try to document, when the provider is going to be free so that we can gather things and talk to them at that time and be organized. We put on our Huddle board the recall saturation so we know that we understand what our patient availability is so that we can, track patients and have them come back at appropriate times so they're not waiting for appointments. We also have all of our current projects and improvement ideas that we're working on, so that we can, grow and become, better and have better access and provide better care to our veterans. Having the current projects and improvement ideas on the board reminds us every day of where we need to focus. Sometimes we have to refocus and remind ourselves oh yeah, I gotta remember to do that. Especially with whole health coming into primary care. Am I asking the whole health questions? Am I, making follow-up phone calls to patients on their health goal? Are we, making sure that we're tracking our patients who, may be a little more complicated? Are we getting our diabetics in to, get their A1Cs drawn? Are they taking their medications? Do we need to provide more education to our patients? How can we, provide them the best health care that they can get? I think that as we make improvements to our daily processes, we're able to provide better care to our patients. So as much as change is a challenge, we need to look at it from the patient's perspective. What is it like when you go to your doctor's office? How is the flow there? How, what don't you like? What do you like? How can we make sure that when our veterans come in, they have the best experience possible so that we provide the best health care in the world?
And I was gonna say, as a new person, I feel like I hope that my primary care doctor does as much pre-planning for me as we do, and I think it's so important. I feel like the Plymouth is a little unique because it's small and the outside providers know us, and when we're talking in the pre-planning, the doctors know the doctors in Plymouth, so it's like a little relationship here. But I think it's great and it's really important, and I think that they're getting great care. Yeah, so just being new to primary care, I felt like this Huddle board, meeting here every day, talking before we meet, I can come to the board, and look to see, what we can improve on, anybody with projects, and just I keep saying pre-planning, but I think it's great just to be able to meet with the providers, on a daily basis or we do, once a week with Dr. Healy, but it's important, and I think it just made it easier for me as a new, I was able to jump right in, and everything's organized, so it's nice.
We actually stand outside of our board that's on the wall, and it tells us all our numbers and how we're doing in our stats, if they went up or if they went down, and what area we need to work on. So I find it to be much better because you can actually see the progress that we've made, and it gets us all together and we're able to communicate and work as a team. So I find it much more helpful, and then when the veteran comes in, you know, it seems like we can spend more time with him because other things we can get done prior to his visit, and it just goes a lot more smoothly.
When they huddle, they know what appointments are on the board and what spots might be open for a patient that might need a walk-in appointment. If they need medical records, that's when they utilize me to try to request medical records for outside providers for their visit. As long as the board's updated, they have their new Huddle sheets that they work off the pre-planning paperwork.
First, you have to convince yourself this is really going to make some outcomes. Okay. So if you don't believe, if you don't trust, if you don't have the value, it's difficult that even the patient will value it or your team will value it. So that it starts from yourself. And also your team should help you in terms of getting to that goal.
Good morning, everybody. Thanks for being here at our monthly team meeting. Since this is only our second team meeting, let's really focus on the team meeting checklist to make sure we are following the correct algorithm. Okay, Mary, MSA blocked our calendars to reflect the monthly date and time of our meeting. Thanks again. She also sends us a calendar invite every month and asks for agenda items. Leslie, our RN care manager, receives the agenda items and creates an agenda for us. Karen, our LPN, is taking minutes and will forward them to everybody after the meeting. Mary, our MSA, will give us an update regarding our access for our patients.
The third next available that we keep track of daily for this team is 0 days as of March 1st. The recall saturation report, which identifies recall reminders and compares that to the available appointment slots, is in green, which means at present, when you see patients, Dr. Buckley, and decide on the return interval, you have no months that I recommend you stay away from. However, if you plan leave in the next year, we can use this report to help us plan. Your telephone clinic utilization is very strong, Dr. Buckley. Here is the chart. We continue to try and identify potential telephone visits versus face-to-face visits at every pre-planning meeting. Karen, our LPN, will give us an overview of our panel.
Okay, so last month we looked at our diabetic patients, but before that, I just want to do a quick review. We have 816 patients on our panel, and 501 of them are shared care, and 177 to 180 of those patients are diabetics. 9 are on home telehealth, and 3 are on home-based primary care. Okay. So, last month we referred to the Vision monthly PCMM report, as well as some spotlight data.
That's right. We addressed diabetic eye exams last month, and as a reminder, we said we were going to focus on our diabetic eye reminders at each pre-planning meeting and continue to track them.
Right, and I began calling patients prior to their appointments and asking them if they're shared care patients, can they bring in their outside records, especially of their eye exams, and I also ask patients who are not shared care if they can make sure they get those eye exams done before they come in for their visit.
That's a great idea. Thank you, everyone. Looking at our agenda, I see that our LPN Karen suggested we look at diabetic foot exams at this meeting. Karen, can you tell us the current state with our diabetic foot exams?
All right, folks, so yesterday and when we were at our daily huddle, our spotlight data showed that our rate for doing diabetic foot exams was down to 50%. So when we drilled down further on that, we found that we were missing our new diabetic patients. That we really were not aware that they were diabetic before their appointment.
In fact, when we review our diabetic foot reminder compliance for the past month, we were only at 85% compliance.
Okay, this is great. How about we share some best practice ideas for approaching this concern?
Well, I think we have a really good process in place for identifying the current diabetic patients with our pre-planning process, and also when we identify them at the morning huddle, because I have my huddle sheet and I know who I should be aware of. But for some of our new patients, sometimes I know they're diabetic when I look at their outside records, or maybe when I talk to them on the phone. But sometimes I don't know. So that for me is the challenge. How do we identify our new diabetic patients if we can't get that information through records or a phone call?
That's a great point. Sometimes I discover this during the appointment from talking with the patient.
Often the patient is quickly heading for the door to leave. And if we don't know you diagnose them as diabetic, then we'll miss our opportunity to complete the diabetic reminders because we typically don't see them after they see you.
That's right. We definitely have an opportunity to improve this before the patient leaves. If I discover a patient is diabetic during my visit, I could bring the patient to your office, Karen.
Could you send Karen and I an instant message so that we are both aware? Then if Karen is busy with another patient, then I could take care of the diabetic foot exam and whatever additional diabetes education is needed.
So that's a great idea to inform both of you. It sounds like we have a great plan in place to improve diabetic foot exams for our new patients.
We're almost at the end of the meeting, so let's review our plan for improvement. We will continue to identify diabetic patients with our pre-planning work and during our pre-planning meetings. On the day of the appointment, we'll continue to identify the diabetic patients who need foot exams so Karen is prepared.
I'll get the team any outside records that are identified during our pre-planning meetings. During our pre-planning meetings, we identify which patients I should call to remind them of an upcoming appointment and which patients the RN will be calling. Maybe I could help by asking the patient if they are diabetic.
That'd be great, and you could let me know, and I can also follow up. I'll continue to call the patients that we identify at a pre-planning meeting prior to the visit, but as we all know, best practice is to be able to catch those diabetic patients and identify them before the appointment so that we can get that foot exam done before they actually see Dr. Buckley, so we'll continue to work on that.
I will be sure to instant message the RN and the LPN if I encounter a new diabetic patient or if there is something else that should be done for the patient before they leave, and I will bring them to whichever team member is available.
Great, sounds like a plan. We should see an improvement in our numbers next month, and hopefully we will have more consistent trending. Don't forget to send me agenda items for our next team meeting so I can put together the agenda.
And I'll get the minutes together from this meeting done in the next day or two, and I'll send them out to everybody. Thank you.